Dr. Nita, you have to unmute yourself. Yeah.
A very good afternoon and a very warm welcome to NITRD Central TB Division and National Task Force Difficult to Treat TB Clinic. On behalf of NITRD, it is my privilege to welcome our DDG Sir, Dr. R.P. Joshi, Directors of the Institute NIRT Chennai and NTI Bangalore, and their team, then state TB officers, directors of STDCs, faculty of medical colleges, district TB officers, medical officers, and all others, a very warm welcome. Introducing the faculty, I am Dr. Neeta Singla, Nodal Officer, DRTB Center at NITRD. On my right is Dr. Rupak Singla. He is Consultant TB and Respiratory Diseases in our institute. And on my left is Dr. Saroj Meena. She is a pulmonologist at NITRD. Now I request our Director, Sir, Dr. R.K. Diwan, to give his introductory remarks.
Thank you so much, Dr. Nita. Actually, I'm so happy to join the Difficult to Treat TB Clinic, which is a flagship program of our institute. Again, after a gap of, I think, 1 or 2 clinics, which I could not attend because of other engagements. I welcome my good friend and our esteemed colleague, Dr. R.P. Joshi, the Deputy Director General TB. He is also so busy nowadays. Most of the time he is involved in such important meetings, and that he has found out time to attend our Difficult to Treat TB Clinic shows his commitment and love for our institute, as well as his desire and zeal and eagerness to learn about the expertise which is spread all across the country. And I am very happy to welcome the Director NIRT and other senior faculty, Dr. Radha Munje, Dr. Vinod Kumar, Dr. Diba Saeed, others who have joined, Dr. Jagdish Joshi, and our own student earlier, Dr. Rishi, who has joined today. Welcome everybody. And I am looking forward to see a very wonderful as well as energetic case presentation and discussions. Thank you, Dr. Nita. Over to you.
Thank you so much, sir. It is our privilege to have our DDG, Sir, Dr. R.P. Joshi with us. Now I request sir to give his remarks.
Namaste, good morning all. Respected Dr. Diwan sir, Director NITRD, Dr. Singla, the faculty for today's meeting, and all my colleagues. I must again take this opportunity to congratulate and appreciate the whole team running this very, very important initiative of Difficult to Treat Clinic. It not only brings academic touch to the public health program, but also helps to solve the difficult cases and do the capacity building of all our colleagues who are sitting in different parts of the country. And thanks to NITRD, now we have in many other states are also taking the cue from here, and Dr. Singla and the team is helping them to develop. And I am happy that many states have already started doing similar clinic in their state. So this is one of the very good initiatives, and for me also it is very good learning experience. So the fact that I am joining is more for learning rather than any other motive. So it is very, very important that we take this forward. So with that, I look forward to another learning experience and wishing all of the people all the best. Thank you.
Thank you so much, sir, for your encouragement, and it is our privilege that our clinic is appreciated so much by Central TB Division. So moving on to today's case presentation, in the current series where the states are being invited by rotation to share a difficult case from their state so that it gives us all an opportunity to learn from them, from their experiences. In this sessions, we have one faculty who presents the case, then we have a state expert, and we have a national expert. In today's session, the state of Madhya Pradesh is presenting. We have Dr. Rishikant Aherwal, who's Assistant Professor Respiratory Medicine at Sukhsagar Medical College, Jabalpur, who will be presenting the case. The state expert is Dr. Talha Saad. He is Professor and Head of the Department of Respiratory Medicine at Bundelkhand Government Medical College, Madhya Pradesh. A very warm welcome to both of you, sir. And the national expert for the day is Dr. Sanjeev Nair, who is Professor, Department of Pulmonary Medicine at Government Medical College, Thrissur. He's also part of National TB Expert Group at the national level. So we welcome you all, and over to Dr. Rishi to present his case.
Yeah, thank you, ma'am. Thank you very much. Thank you very much, all the respective faculties for giving me this chance to present on this forum. Today, I'm myself, Dr. Rishikant Aharwal. I'm working as a assistant professor in Department of Respiratory Medicine at Sagar Medical College, Jabalpur, and I will be presenting today's case discussion. It's a very good case as per learning and for expert opinion also. Sir, can you share my slide screen, please?
Access been given. हाँ, आपको एक्सेस दिया हुआ है डॉक्टर ऋषि, आप ट्राई करें अपनी तरफ से. Share screen and then open your presentation. पहले presentation open करके उसको minimize कर ले and then share screen पे जाके उसको खोल ले. In case it doesn't open, we will do it. Not an issue at all. डॉक्टर ऋषि हम यहाँ से कर दें. ठीक है, we are doing it. You are muted. आपको Yes, Dr. Rishi.
Just a second. I'm just looking.
Are you able to see the slides?
Yes, ma'am. But the only thing is, I'm not able to I'm not having access of these slides. So,
no, you cannot change. We will change from here.
Actually, ma'am. Okay. So, ma'am, can I get back to my first slide? Ma'am, I just try once if I can share my screen because it will be
नहीं,
easy.
आपका screen एक बार आप देखिए change हो रही है क्या? It's your screen only.
No, ma'am, it's not changing. So
I think Dr. Rishi, you let the persons change the slides from here. You go ahead. There's no point wasting time. now.
okay, sir. Yes, sir, sure.
Okay, so we are doing it from here.
Okay, ma'am. Ma'am, my screen is visible. Yes. Yes. Okay. So today's this case is difficult case of EPTB. So can you get the next slide? Yes. So the case is a 25-year young female, which is referred to a nodal DRTB center for the initiation of DRTB regime in June 2022. Patient presented with complaint of swelling in the cervical region, multiple swelling since 1 month. There was no history of cough, hemoptysis, or chest pain, and the swellings were gradually progressive and soft in consistency with draining sinuses. In the past history, patient has a history of EPTB, cervical lymphadenopathy, that was diagnosed in June 2022 and was started on ATT. The diagnosis was made on the basis of FNA that was performed in June 2022, and the FNA sample was sent for cytology and CB0. So cytology shows necrotizing lymphadenitis, and CB0 report shows that MTB detected and rift resistance was not detected. Later in August 2022, CECT NAC was performed. It shows necrotic mass in left lower cervical of size measuring 6.5 into 3 centimeter, multiple nodes in right infraclavicular and right axillary region of size 3.5 into 2.2 centimeter. So Initially, ATT started for drug sensitive TB, that is HRZD first line, for 2 months. And when repeat CECT NAC was done, like first CECT NAC was done in August, the treating physician, they added injection streptomycin for 2 months, tablet levofloxacin 750 mg for 2 months, oral steroid for 1 month, and HRE for 4 months. Next slide, please. So later, there was persistent lesion at 6 months. So repeat CBNAT and first line LPA was done. This CBNAT result shows MTP detected again and RIF resistance not detected. Meanwhile, first line LPA shows RIF sensitive and INS sensitive. So considering it to be a persistent lesion, ATT was extended for 3 more months. So total duration will be 9 months. So at the end of the 9th month, patient noticed that there is a swelling in the left axilla. So previously there was swelling in the right axilla. Now she noticed swelling in the left axilla. So repeat CECT was performed in month of March 2021, which shows both axilla there was a conglomerate nodal mass. Right mass, axilla mass measuring 2.7 into 2.7 centimeter. Left axilla 2.5 into 2 centimeter, and with multiple mediastinal and large lymph node. So again, repeat FNA was done and CBNAT was done. Again, the CBNAT report shows that MTP detected and RIF resistance was not detected. So IND was performed from the right axillary abscess, dressing was performed, and ATT was extended for further months. So this was the initial X-ray that was taken in month of June. As we can clearly see that there is no parenchymal involvement in this X-ray. So it was a clearly a case of EPTB only. Next slide, please. These were the CTs that were performed. First CT, okay, so this was the first CT that was performed in March 2021, which shows that there is a mass in right axilla and left axilla, which was compared with the previous. And this next MR was performed in 12th July 2021, which shows that there is a persistent lesion and an enhancing sinus tract. Can I get a next slide? So multiple consultation was done by the family regarding her condition and was advised to continue ATT for drug sensitive TB. As left axillary swelling was persistent, a repeat FNA for CBNAT and culture was done on 25th of May 2021. Again, this left side FNA done and CBNAT shows that MTB detected and RIF resistance was not detected. So again, patient considering her to be a recurrent case, and ATT was restarted by the treating physician in May 2021. The culture report was available after 3 weeks and it was negative. There was a no growth. Next slide, please. In July 2021, there was a oozing of pus in the right axillary region. So MRI fistulogram was done and it shows a well-defined homogeneous enhancing sinus tract measuring 10 mm width in left axillary region with external opening to skin, few enlarged lymph nodes, well-defined lobulated soft tissue 1 and 2 of size 1.8 into 1.5 centimeter in anterior segment of right upper lobe also. So this time there was involvement of lung also in the consecutive MR which was performed. So at the end of the 6 months, swelling was reduced to just palpable but not completely resolved, and hence ATT was stopped in November 2021 as 3 consecutive cultures was negative. Things went well for some time, and after 6 months, patient noticed a swelling in the suprasternal area and left supraclavicular right axillary area and swelling in the posterior thoracic wall. So these swellings were gradually increased in size So reconsultation was done and repeat FNA was performed. Again, the CB0 sample sent for CB0, and this CB0 sample shows that MTB detected and RIF resistance not detected. So again, the patient was started on ATT in the month of May 2022. First line and second line LPA was not available due to COVID, and there was some unavailability of the kits. Meanwhile, the culture was also unavailable, so it will not be able to perform. Next slide, please. So, meanwhile, in this course, even the multiple consultation was performed, done by the family regarding her condition, and even other pathies consultation was also done meanwhile. Then then patient went to NITRD for expert consultation in June 2022. At NITRD, repeat CB0 and culture was done. CB0 shows MTB detected, RIF resistance not detected. Culture report were awaited by that time, and later there was a growth of MTB, and it was found to be sensitive to first and second line drugs. So this was the CT that was performed in July after this FNA. This repeat CT was performed in the month of July, which clearly shows there is multiple enlarged discrete conglomerate lymph nodes in right axilla, left axilla, and on the thoracic wall also. Next slide, please. This was the Nikshay ID, and in this Nikshay ID, it is clearly visible that every time there was a repeated CB0 and FNA was done, and every time the report of the CB0 shows that there is a MTB was detected and RIF resistance was not detected, RIF resistance was not detected, and in the first LPA also, it clearly shows that MTB detected and RIF is sensitive and INH is sensitive. So every time when the CB0 is performed, there was no evidence of drug resistance, and every time it is found to be MTB detected and RIF resistance not detected. Next slide, please. So what are the considerations that we have with the case? Looking back to the history and other parts, whether the diagnosis was in this case, the diagnosis was definitely correct because MTB was detected and RIF resistance was not detected at in any of the case or in the test. Regime for drug DSTB was started, that is HRZD. Dose of the drug was according to the weight. Compliance for the treatment was ensured. Patient was compliant to the treatment. There was no interruption of the treatment due to any ADR. The supply of the drugs were also ensured, and the duration of the treatment was also adequate. Okay. So what was wrong in this case? Anything that can be done? Please, next slide. Next slide. So what to do next? Now we have a patient of a young female patient of age 27 years who taken ATT for almost 16 months. It's a recurrent case of EPTB. There was a recurrent cold abscess was there as per the complaint of the patient. There was an exposure of second line drug for more than 1 month. Previous CB0 report shows MTB detected, RIF resistance not detected. None of the molecular tests shows any evidence of drug resistance. Next slide, please. So, to reach to the final diagnosis, considering her past history, previous CB0, LBA, and present CB0 report, history of exposure of ATT, history of ATT for 16 months, history of exposure to second line ATT drugs for more than 1 month, considering her clinical progression of disease and her symptoms, final diagnosis was considered as a clinical failure by the treating physician and planned to start on MDR regime. So finally, she was labeled as a clinical failure to the treatment. Next slide, please. So treatment and regime. So as patient was diagnosed to clinical failure and there was involvement of lung also. So she plan to start on all oral longer MDR regime. So as per the PMDT, the all oral regime should contain drug from group A and B. So bedaquiline, levoflox, linezolid, clofazimine, and cycloxine was the initial regime that was according to weight is framed, and pre-treatment evaluation was started, and family and patient was counseled about the treatment and the ADRs of the drug. During pre-treatment evaluation, patient diagnosed to have a bilateral low frequency mild sensorineural hearing loss. Meanwhile, both patient and family was not agreed for clofazimine due to the darkening of the skin. So considering this situation, the regime was reframed, and as per the replacement sequence, the patient regime was reframed, and drugs that was started was bedaquiline, levoflox, linezolid, cycloxine, and delaminate according to weight, and started on EPTB from July 2022. This was the audiometry report, which shows the bilateral mild sensorineural hearing loss during pre-treatment evaluation that was diagnosed. Next slide, please. So, when the patient started on all over a longer regime, after 2 months of the treatment initiation, patient started having pain in left knee with mild swelling. Patient was managed with short course of NSAIDs and steroids. Her uric acid was in the normal limit, R factor was negative. Patient responded well to the short course of treatment and was continued with the same regime. So there was a clinical response after the initiation of the treatment, and the cervical swelling started reducing. Next slide, please. At the end of the 4 months, patient again presented with complaint of difficulty in standing from sitting, pain in both ankles, joint pain, discoloration of tongue and teeth, and insomnia. So evaluation for tendinitis, arthritis, and discoloration was done. Orthopedic opinion was taken, and she was diagnosed to have sinusitis with tendinitis. So considering it as a ADR, levofloxacin was stopped due to ADR in October 2021 of 22 after 4 months of treatment. And patient continued with regime containing 4 drugs, that is bedaquiline, linezolid, cycloxine, and delaminate. And there was improvement in her symptoms also. So by the end of the 5 months, again patient presented with complaint of pain and burning in the feet, insomnia, and low mood. Neurologist and psychiatric opinion was done. She started developing peripheral neuropathy. So initially managed with pregabalin methylcobalamin combination for peripheral neuropathy, risperidone and hypnotics for low mood and insomnia. Dose of linezolid was reduced to 300 mg. There was a slight improvement in her lower limb symptoms, and considering it to be irreversible, later the dose of linezolid 300 mg was stopped, and linezolid was stopped at the end of the 6 months. Next slide, please. So regime at the end of 6 months or in the continuous phase. So as per the PMDT, from 6 months onwards, the drug regime should contain at least 4 drugs, that is levoflox, clofa, cycloxine, and linezolid in half dose. In this case, we have delaminate and bedaquiline, which is stopped as 6 months already completed. Clofazimine was not added initially. Linezolid was stopped due to peripheral neuropathy. So in this case, only 1 drug is left in the CP. Meanwhile, injectables cannot be given after 6 to 8 months of the initial treatment. And moreover, the patient also diagnosed with mild sensorineural hearing loss. So at the end of the 6 months, this is the case scenario. Next slide, please. So what to do next? And I will just end my presentation here, and I will hand over this expert opinion to the respective faculties to give their remarks and to guide us further for the treatment and for this patient. Thank you very much, sir. Thank you very much, ma'am.
Yeah, thank you, Dr. Rishi. An excellent case and a very clear presentation. So I will just give the history in brief because many people have joined since you started. When you started the case, we had 165 spokes, and now we have 330 spokes. So almost 200 people have joined since the time you started. So it's a 25-year-old girl with bilateral axillary, supraclavicular, and mediastinal lymphadenopathy for last 3 years. There has been non-response to first-line treatment. Once it responded, but again there was a recurrence. and multiple FNACs have done where the MTB was detected, but patient was sensitive to rifampicin and INH. Even culture showed sensitive to all the drugs. Patient had primarily taken only first-line drugs for more than 2 years, and 4 months of levo was taken in 2020. In July 22, patient was declared as clinical failure and started on modified longer oral regime, but patients started having multiple ADRs and the drugs had to be stopped. So bedaquiline and delaminate were stopped at the end of 6 months, whereas levo and linzo had to be stopped due to ADRs. So now she has completed her 6 months of intensive phase, and now issue is to decide for her continuation phase what drugs are to be given. So before I invite our state expert, Dr. Talasad sir, if there are any questions on the history or investigations, you may ask them to Dr. Rishi, and Dr. Rishi would clarify the history. So there are questions in the chat box, and Dr. Saroj will be taking those questions to you, Dr. Rishi.
Dr. Rishi, so Dr. Jan Sankar, he's asking, will there be any role of TDM in this case? Because patient was sensitive, drug sensitive tuberculosis, failed on primary rejection.
Yes, sir. This is a very good question. I think this answer to be given by the expert, but for a timing, as per the TDM, there are few limitations with the TDM. First, it should be performed timely. That means it should be performed within the 6 months of initiation treatment, and if we found that there is a failure to treatment. In this case, the patient already took medication for 16 months. So if we go for TDM and then again we are having clear-cut report which is showing there is a drug-sensitive pattern. So as per our country, we have limited sources. Getting sample for TDM to be performed after 2 hours, because 2 hours drug levels is important in TDM, and the second dose to be taken after 6 hours, which can differentiate between the delayed absorption or malabsorption. So we need expertise for this. Meanwhile, a financial cost is also a problem. So the patient, because already taken ATT for 6 months, so in this case, I don't think that TDM is going to work. Yes, in the beginning, if after the 6 months of the failure of the treatment and we could have done that TDM, then in that case, it could be beneficial for the patient.
Thank you, Dr. Rishi. We will take in detail TDM with the expert again. We'll discuss it again. So there's another question from the history part. There was response with anti-inflammatory analgesic was assessed before stopping levofloxacin?
Yes, there was a response, but the problem was the blackening of the tongue and the pain in the knee, which was previously improved. But after a few days, after a short course of this medication, again patient is starting having this pain in the lower limbs. So as per the orthopedic opinion, they decided to discontinue the drug. So that's why the levofloxacin was stopped.
So histopathological examination of the FNAC sample was done in this patient in the beginning.
Yes, initially, no, basically that cytology was performed and it was showing only necrotizing lymphadenitis. So in every time, whenever repeat FNA was done, the cytology report was consistent with necrotizing lymphadenitis, and it was suggestive of tubercular etiology itself.
Okay, thank you, Dr.
Thank you.
So I think these are the questions on the chat, but if somebody has any questions, they can ask directly. They may raise their hand and we'll invite you for the question. Since I don't see any question, I would request Dr. Talasad to give his comments for the case.
Yeah. And thanks
Dr.
everyone. It was a nice presentation, Dr. Rishi, and you presented it very nicely. At this point of time, whenever the patient is not responding to any of the treatment, like in the first line treatment, and when the patient is seen to be like sensitive, like at the end of the treatment, 16 months, as you have presented, that the patient was sensitive to first line and second line drugs. And even then the patient is not responding, the first thing that should be coming in the mind is about the compliance of the drug. The second thing that should be coming in the mind is the compliance of the drug. The third thing that should be coming in the mind is the compliance of the drug. And then after, you should think beyond that. There are many attendees over here, and they might get swayed away, or they might get something new about TDM, or something very fascinating thing about the TDM. But in most of the cases, I have seen that the patient is not compliant to the treatment. So definitely the compliance should be checked in every time the patient is returning to your clinic, the first and foremost thing. So the importance of compliance cannot be overlooked. Now, in this case, at the end of the 16 months, even when the patient is not responding, and then it was decided as a clinical failure, and then the patient was put on the second line drugs, I think the most important medicine, the rifampicin, should be included in that regime also, because as you have seen, that in due course of the time, the number of medicines was gradually decreasing, and we have left with very limited number of medicines. Like at the end of the 6 months, you can see this is only the delanamide and bedaquiline and cycloserine. So I think that rifampicin, which is very potent and that is also sensitive in this case, can be included in this regime. So this is very important thing. The second important thing also is about the knowledge of TDM, because definitely TDM is one part, therapeutic drug monitoring is also one of the part which must be known to our fraternity. Like many of the doctors are not exactly knowing about this therapeutic drug monitoring. Definitely there are some shortcomings with this therapeutic drug monitoring, like the availability of this therapeutic drug monitoring across the country. Second thing is the cost of this TDM. Third thing is the whole infrastructure, like the patient shall be subjected for repeated testing simultaneously, and then that sample is sent by courier. And there are some problems in regular TDM. And also that the literature which are present for this therapeutic drug monitoring shows that whenever the patient is having like diabetes mellitus or HIV, in these cases, the therapeutic drug monitoring plays an important role. Like in this case, the patient was not having any comorbid illness, so the patient was can be missed like that of therapeutic drug monitoring. But definitely therapeutic drug monitoring or TDM is a very important thing which must be looked upon whenever there a patient is not responding and the patient is rifampicin sensitive, and the patient is having increasing disease in due course of time. Am I audible?
Yes, sir, you're very much audible.
So lastly, the three important things. First is the compliance of the medicine must be looked upon. Like you have said that you are very well assured with the compliance. That is very good thing. Second thing, when the patient was sensitive to first line and second line medicines, then the addition of rifampicin can be considered. And the third thing is the knowledge of therapeutic drug monitoring and its proper placement of therapeutic drug monitoring whenever the patient is not responding to your medicines and the patient is gradually increasing with the disease.
Thank you, sir. Thank you for your comments. Are there any other comments from the House regarding the treatment part? Before I invite Dr. Sanjeev Nayak for his comments on this case.
Are there any questions in the chat?
Yeah, so let's take some questions from the chat that we have.
So, one of the question is why rifampicin was not given as it was said. I think that has been answered.
So I think Dr. Sanjeev can add to that. Dr. Sanjeev, sir, we'd like to have your comments as to why rifampicin was not added with bedaquiline containing it.
Thank you. Thank you, Dr. Singla. Let me start by again thanking the team for the opportunity to interact with all of you. I hope I'm audible. So
Yes, sir, you're very clear. Thank you.
I must congratulate the team that our difficult to treat clinics are actually evolving. So when we started with, in the beginning, we had kind of straightforward cases where it was just a lack of awareness of the guidelines and all that. Now, when the discussion, listening to the discussion, now it's very clear that all our participants are well versed with the guidelines, and it is more of the kind of case that we are discussing today is a really difficult case. I'm sure that Dr. Rupak Singla will agree with me that this particular case, each of us might have our own opinion. It's going to be quite different in the way we actually approach the case. With your permission, can I just share a few slides? So just the idea is not to, start all over again. The idea is just to, kind of share.
Sir, would you like to take the questions first and then maybe your slides will answer all our questions? What do you
Maybe, madam, I think I saw some of the questions. Maybe when I'm coming to that point on the slide, I can cover that as well.
Sure.
So we'll go take it together.
Yeah, great.
So, like I said, this is a really difficult case. So you have a case of non-recurrent, recurrent non-responding TB, which has been on treatment, patient has been on treatment for a long time. We are again discussing extrapulmonary TB, which at times is more, complicated, more difficult than pulmonary TB, even though one would assume that, because of the lesser bacillary load and all that, we could have an easy time with that. And lymph node TB obviously should respond well to a 6-month treatment, but this case obviously has given trouble to all of us. And the patient has gone through multiple regimes over the last 3 years. So it's a long treatment that almost 2-3 years this has been happening. Of course, the current dilemma with which Dr. Rishi stopped was the kind of, Dr. Gunjan Upadhyay probably can mute. Yeah, thank you. So the current dilemma is on how to design the continuation phase, which is where we stop. Now, generally, when a lymph node TB is not responding to our treatment, these are the traditional questions that come to mind. So you start with asking, is it TB? So often what happens is you have repeated granulomas or even caseating granuloma on histopathology. But then, it could be so many other things which form the granuloma. And the other thing, obviously, is that, many of the caseating granulomas could be non-tuberculous mycobacteria, which is often, we don't really consider. We go ahead with thinking that, is it a paradoxical reaction? When you take drugs, many of the patients can have new lymph nodes appearing, so already the nodes which are there might increase in size, make it break down to sinus formation also. Is that a paradoxical reaction that we have in this case, or is it active TB, where it's not just a paradoxical reaction, whereas the TB is actually continuing despite our treatment that we are giving? And obviously, the last question that we all ask is drug-resistant TB. I must congratulate the team for having worked up the case so well, and Dr. Rishi presented it so well as well. So all these questions were actually answered by Dr. Rishi very well. So, you have had technology available today. So the NAT, LPA, MGIT, and everything put together actually show, that this is MTB detectors. It's an MTB complex rather. So it is not an NTM, and we know that this is TB. So there is no dilemma on that. So that Dr. Rishi already mentioned to us. The other thing is, it's the paradoxical reaction for 18, 19 months, 20 months of treatment. That is not what you consider. And even otherwise, towards the end of treatment, a culture was done which came as positive. So we have to consider that the TB is still active despite the treatment that we give. And the last bit on drug-resistant TB, of course, we have multiple tests in this patient which have confirmed the fact that there is no resistance either to INH or rifampicin or even to second-line drugs which are tested. Now, moving ahead, so the regime, I totally agree with most of the things that are presented. My only slight disagreement with this particular management strategy in this case was, while the INH rifampicin, pyrazinamide, and ethambutol was being given, we actually added a levofloxacin to the regime at that point, which I would strongly, oppose it happens at my state level, because the fact is that later at some point, such patients do end up needing a levofloxacin or a quinolone, which actually happened in this case. So you actually have given quinolone for a long period, and then maybe 4 months or more, and then now when you give a levoflox in a new regime for whatever regime you were given later, so this is a drug which has already been used for the patient. So that brings in a bit of dilemma. So I would have preferred that we continued with the first line drugs, and later at a point, whenever needed, we could have gone in with the second line drugs. We could have, the extension of the regime is also a controversial thing. How long do you extend the regime? But of course, this patient was managed well. And then, the restarting of DSTB regime is what actually happens. But the problem is often we end up starting the regime again and again. So from my point of view, what we would do at our state level in Kerala in a case like this, these are the points that we would. So like somebody very rightly pointed out, from the participant side, a biopsy, a histopathology would be done. And then you also send the biopsy specimen for a culture. In the culture, generally what we ask for is, we also ask for a phenotypic DST, because genotypic DST in most cases works perfectly well for us. It is fine. It gives very good results. But at times when you have patients like this who are not responding very well, when you do a phenotypic DST, there is a possibility that you might get some kind of resistance. And we have a good link up with our NRL, and we also ask for a sequencing in a case like this. So maybe some of the locus of resistance which are not picked up by your line probe assay or your gene expert could be picked up. So these we do it only at our NRL. We don't send it to private or make the patient spend money on this. So our NRL is supportive on this. So this is only for exceptional cases. I totally agree with Dr. Tala that you did not do this for every patient. You should not take the message from this that this is what to be done for all patients. This is only for this specific case who has not responded for like more than 2 years of treatment. The histopathology also is important. We might pick up other pathologies. I totally agree with the state expert that first thing I would look on a case like this is whether the patient was actually taking the drugs or not. Now I understand with after discussing with the seniors here that this was a kind of a VIP patient. And we often assume that such patients, they know everything and they would take drugs, but that would not be enough. What I generally do at my level is, in these cases, I put in enforced DOT. So at some point, I don't believe the history that they give that, I'm taking medicines, I'm taking medicines. At this point, we go back to our good old RNTCP days and then keep the drugs with somebody else and ensure that the patient takes the drugs under supervision, which makes a huge difference in many patients. At that time, you realize in many patients that they were not taking the drugs at all. And of course, this has been discussed a lot, therapeutic drug monitoring, TDM. Again, we have a link up with a government sector institution, which does very high quality TDM for us. So again, we do send in such cases. Again, the points are very well made by the state expert that it should not be the first option that you do. You should look at other options and only then you go with the TDM. And also when you do a TDM, our Dr. Rishi, who presented, also very clearly said that you need periodic blood level, blood to be taken. And often for us, the patient has to travel like 800 kilometers to get a good quality TDM done. So it's difficult for the patients as well, even though the test is free by our support that we get, but then, the travel and everything is costly for the patient. The point here is that there are many labs offering non-standardized TDM. So, the temptation is that we keep sending to some private lab. Those will give you very erroneous results. So you should not go with labs like that. Standardized testing should be done. And the last bit, which was not really discussed today, I would also look for some form of immunodeficiency. So I have had cases like, chronic granulomatous disease. We have had patients on various, TNF-alpha antagonists, biologicals and all, who keep on recurring with lymph-TB and all like this. So the problem is that even though your drugs are okay, it is actually the body's immunity which has to take care of the remaining bacteria, and that doesn't happen because there is some problem with with the immune system. What you need is to look at the cell-mediated immunity, the CD4, CD8, and things like that. Often when you send to a immunologist, they look for the antibodies and all, which may not be the right way of looking at it. So that problem is also they look for immunodeficiency, but it may not really be done. So look at the T cell function and all. That is also something we do. So this is a kind of protocol that we would do in cases like this in our state, and I think I will be looking for opinion on that. Now, Dr. Singla was asking me on the drugs. So having made a decision that I'm stopping the first line drugs and this is a clinical failure, and then starting the patient on a second line regime, in which case, in this case, we have started on a all or longer regime, then I would not add rifampicin to it. Rifampicin has been taken for almost 2 years by this patient, and I'm not really comfortable with the interactions of rifampicin with other drugs. In that case, after having taken the drug for 2 years with bedaquiline, delamanid, and all being added to the regime, I would not consider rifampicin. So I totally agree with the regime that was given to this patient. So I'll go only with the second line drugs in this particular patient. Of course, the drugs were stopped in this patient. So this has been discussed by some of the delegates who are there for meeting today. So particularly on levofloxacin, whether we could have continued, but then the orthopedician's opinion is final on that. Linezolid, I agree, you know, a young girl with severe peripheral neuritis, you would not want linezolid to be continued. So that is also stopped, justified. The clofazimine, just because of skin color, very important drug, which was not given, I would have felt there a slight opinion that maybe strong counseling and all that to say that, you know, this is a very, very difficult case. Despite all the drugs, a patient is not responding. Why shouldn't we try the clofazimine out? I would have been more proactive, pushing the family and the patient to start clofazimine. Now, currently, our problem is that the patient is only, I mean, the possible drugs are bedaquiline, delamanid, and cycloserine. So what are the options? That was a question with which Dr. Rishi stopped his presentation. So, you know, you need at least 3 or 4 effective drugs in your continuation phase. Having said that, if you have bedaquiline, delamanid for the entire continuation phase, if you're continuing the whole drug, you have cycloserine also in the regime. Maybe those 3 drugs would be good enough for a continuation phase if we could do that. But then, you know, this patient already had some mood elevation, mood changes, and you might consider stopping the cycloserine maybe at some point. So then it's always safer to have 4 drugs in the continuation phase. In which what drug would you add? Again, I would go back to clofazimine, which is a group B drug, which is a more effective drug. Can I convince the family that this can take? You're still not going to take the drug. Maybe I'll go with ethionamide. So maybe add bedaquiline, delamanid, cycloserine, and ethionamide for this patient for the continuation phase. Now, if I'm not able to continue both bedaquiline and delamanid, maybe if I'm continuing only bedaquiline for the period, then maybe, bedaquiline, cycloserine, and clofazimine, if they agree, is a reasonable regime. But if I want a stronger regime, I might go with bedaquiline, cycloserine, ethionamide, and pyrazinamide in this case. Pyrazinamide, the patient has been using multiple times in the past. So, maybe consider ethionamide with PAS, which adds to the thyrotoxicity to drugs, which can actually add on toxicity and the difficulty of taking PA in terms of side effects and all that. So these are the options available. Given a choice, I might go with bedaquiline, delamanid for the entire continuation phase, go with cycloserine, and maybe because of the mood problems and all, add one more drug, which if they agree to clofazimine would be my choice drug. If they don't agree, maybe ethionamide. So that would be the continuation phase I give to the patient. The last bit is, would you consider surgical options also? Many of these cases, where you have multiple nodes. If all the nodes are accessible, you often find that if you surgically remove these nodes and the sinuses and the abscess and all, which is possible in some of our cases, this particular patient, it might be difficult because of the nodes being present all over the body. In that case, maybe it's difficult, but if it is possible, if you remove all the nodes, you often find that, it really works along with the drugs that you give. So, that is also one option that you could consider. So these are my suggestions. Like I said, started with. Now, all these are, there are no right and wrong answers in such a difficult case like this. And I'm sure that the other senior faculty would maybe agree or disagree with me on this. Dr. Neeta Singla, have I answered the questions in the chat box? Was there something which I did not cover?
No, perfectly. So there's only one question that needs to be answered.
Sir, you've answered almost all the questions which were there in the chat box, except one thing. Was the use of steroid when the patient developed joint pains and all justifiable in this case or not? And we know that the levoflox has a side effect of causing tendinitis. It is due to the drug injury. Was it justifiable in which case?
So you're muted.
Very early in the treatment, if it is a paradoxical reaction, it's possible. If you have multi-system involvement, neurological involvement, and all that, some generalized TB in this case, I might consider adding steroids as a counter to the severe paradoxical reaction. But other than that, after 2 years of treatment and all, at this point, I would not think that steroids may do much benefit unless there is a CNS involvement, which actually mandates the addition of steroid in that case.
So one more question related to this, like we stopped levofloxacin after the patient developed 8 years. would it be great if we could have replaced it with moxifloxacin when we have stopped levoflox? So we could have a better regimen CP.
Yeah, but I mean, the patient having ADR tendinitis to a quinolone, which led to the stoppage of quinolone, one has to be cautious to add one more quinolone in that scenario. You might consider adding a different drug, which is what was considered in this case. I would agree with the management of the case with respect to both stoppage of levoflox and the linezolid. Yes.
Dr. Nita, can I add a little
Sure,
comment?
sir. Yes, sir.
Yeah. Yeah, you see, being a surgeon, as Dr. Nair mentioned about the surgical options, because this patient has multiple system involvement, I would of course not like to touch it. But if this was just limited to a particular region, then we would have definitely gone ahead with a surgical excision. Another thing, because such cases have been troubling us ever since all of us have been working in TB hospital. 2 or 3 other things which we have seen. Number one was the vitamin D levels. Occasionally correcting vitamin D levels, drugs start to work. I don't know whether it is relevant. Another thing, Dr. Puri, I saw was earlier in 1990s, we were working on a laser project, lasers. And if you irradiated those lymph nodes with lasers, somehow miraculously these lymph nodes, when they were making trouble, they used to disappear. I don't know in the present day and age with all this much more information with our hand, these things can still have a role. And the third thing about sinuses, because sinuses have been coming to me off and on, then in those situations, we have sometimes applied this cod liver oil dressings on those sinuses, and they have also occasionally worked. These are all treatments from the pre-chemotherapy era of tuberculosis, and occasionally in desperate situations they work. So that's what I wanted to contribute. Over. Thank you. Thank you.
Thank you, sir. Thank you for your comments. Dr. Singla, would you like to add?
Yes. First of all, thank you very much, Dr. Rishi. You have been a student of this institute and a bright student, so I feel proud that you are presenting today and presented very well. And of course, the state expert, Dr. Talha Saad, he emphasized a lot on the DOT, that is direct observation weather. So I think very, very correctly so, and his other comments were also very, very apt to the case. And Dr. Sanjeev Nair is a seasoned test physician and a senior test physician also. And all this comments, practically he has covered all the aspects. There are a few points which I would like to mention. Some of them may be the repetition. So first thing, as Dr. Sanjeev also said, is the use of clofazimine in this case. You see, it's a group B drug, very effective drug. It should have been used ideally from the beginning. I was involved in the treatment of this case from July 22 onwards when this regimen was framed. The patient started the treatment at the age of 25 years. By the time she came to us, she was 27 years. Marriageable age, family was looking to get the daughter married. And they were very, very much, despite multiple repeated counseling of the patient and the family, mother is also a doctor, they just refused that no, we will not like to use clofazimine at all. Even at a later stage when we were switching at the end of 6 months, she refused for the use of clofazimine, which is unfortunate. But at the same time, I must say that we have seen in the last few years, this 10, 20, 25 years, clofazimine really causes very bad darkening of the skin. And it practically happens in almost all the cases. Some cases it is less, some cases it is more, and it is more in cases who are fair in color. So it is easier said than done that you just tolerate this. And I have seen whatever skin people may say, it takes months or years to go. Some of it remains, the skin looks so dark brownish, blackish, and scaly. The moment patient enters the OPD room, you can make out it is because of the patient is on clofazimine. So we really have to take care of it. We have to counsel. Before starting also, we have to counsel the family, we have to counsel the patient that this can happen, so that mentally they are prepared for it. Tomorrow they should not blame. And I remember one case that is a long time back, where he was a difficult case of XDR-TB. He did well, was cured, but then after some time he came to me with 2 photographs, one of his before the treatment started and one after the treatment has started. And now he was looking so blackish, and he was from a hilly area from Jammu and Kashmir. He said, better you could have allowed me to die rather than giving me a drug which has made me like this. Now nobody is sparing. So that was the point. I really feel that we should not take the this dark discoloration of the skin reaction of the clofazimine lightly. Although I'm not saying in this case clofazimine should not have been tried, It must have been, but the family and the patient just refused. Second thing is peripheral neuropathy, which started at 4 months of treatment. You see, what I have learned in these few years is whenever there's a peripheral neuropathy, commonest, of course, agent is the linezolid. We must detect early. Detect early, that is the solution. In case we are late, this leads to axonal degeneration and it leads to permanent neuropathy, which is painful also, which is quite painful to the patient, and it may be irreversible, may remain the rest of the life, and will also curse the doctor who had given this. So once we detect it early, that is the time we can reduce the dose to half. Give some symptomatic treatment like amitriptyline, we can try mecobalamin, we can try then these drugs. We must take the opinion of the neurologist. We should get the nerve conduction studies done. But these are things are possible only when you detect early, at an earlier stage. Otherwise, in case patient progresses to moderate or severe neuropathy, then these things they don't work. And pyridoxine does not help in preventing the linezolid-induced neuropathy. That also we should remember. Coming to TDM, we have been fortunate to do TDM in almost more than 70-80 cases, and we have learned some points from the TDM. Of course, there are technical difficulties, but we could solve them. The patient has to be on the medicine for about 7 days first, then at the same time of the day. And then on the 8th day, we admit the patient. We bleed the patient 2 hours after taking the medicine. And then there is a procedure that you first centrifuge, collect the plasma. In the plasma, you add ascorbic acid, 10 microliters in the 3 ml of this, and then pack it properly. And a cold chain has to be maintained. And we are tied up with the NIRT Chennai, and must thank the team of NIRT, including the director, who had permitted us to carry it out there. But many times the cold chain could not be maintained because the courier, they delayed the delivery of the this blood sample to these people. And we must do it, as Dr. Sanjeev said, from a place which is reliable. Otherwise, taking a wrong decision will not be a good idea. Second thing what we learned was, in case you are able to detect the patient early, say 3rd month, 4th month, or at the most 5 months, then increasing the dosage alone may help. Patient may be cured if you just increase the dosage in cases where the dose was found, where the blood levels were found to be. In case patient has taken 12 months, 15 months, like in this case, even if you do the blood levels, you demonstrate the levels are low, but by using the same drugs, increasing the level will not work. That is what we found in our series. And here you have to add the second line drugs, with or without the first line drugs with dosage increase. So that was the message which we got from this experience. And in the same flow, I would like to say that in this case, because we were making the regimen, we considered the, as Dr. Salah said, adding rifampicin being sensitive. But patient had been taking, this was the one drug which patient had taken throughout in these 2 years. And secondly, rifampicin has drug interaction with bedaquiline. It leads to reduced levels of the bedaquiline. And in this case, bedaquiline was very important drug, being the saddle drug, being the sterilizing drug. We wanted to give the patient a regimen which would work. So we decided that not to use the rifampicin in the current regimen along with the bedaquiline. Regarding what regimen should be now, so patient has completed 6 months. We are left with extending the dose, the duration of bedaquiline and delamanid, and patient was on cyclosporine. And as you notice, patient was started having some low mood, some depression. So this was not the time where we could not rely on cyclosporine alone. That third drug, in case we keep as cyclosporine, and tomorrow in 1 month, 2 months, 3 months time, we have to stop the cyclosporine. We are left only bedaquiline delamanid. So we added ethionamide to lower down. Injection was not a choice. Already patient has completed 6 months. There is sensory hearing loss. So the injection was out. Pyrazinamide, patient had taken it before 2-3 times. So again, not a good choice. And usually in MDR, in these cases, pyrazinamide should be considered if you have a lab report which is sensitive. Of course, it was sensitive in this case, but because patient had taken it multiple times, we did not use the pyrazinamide. We chose ethionamide as that was sensitive. So in that case, we had 4 drugs: bedaquiline, delamanid, cyclosporine, and ethionamide. So tomorrow, even if we have to stop one of these drugs, we have 3 drugs with us. That was in our mind, so we did that. And as we followed up the case, at 10 months of treatment, even cycloserine had to be stopped because of this CNS and psychotic side effects. So again, we were left with 3 drugs. PAS we considered, but 2 main things for not using PAS one was that availability. Second, even if we could make it available, it is very, very difficult to give ethionamide with PAS. As Sanjeev also highlighted, that it is practically impossible for a patient to tolerate both the drugs. Such a bad taste in mouth, the gastric intolerance. So in my life, I have never been able to use the 2 drugs together. Whenever we have started, within few months, we have to stop one of them, and usually PAS in this case has to be stopped. So we did not choose PAS, we just gave ethionamide, making it the 4-drug regimen. Regarding the steroids and synovite in this case, patient had already taken 16, 17 months of treatment. So, and now you are using a regimen which you do not know whether it will be good or not. So using a steroid in a TB case while he is on a regimen, which is really, we are not sure whether it's a right regimen for the patient. Plus, indications are very few of using steroid in a case of synovitis, especially it is drug induced. So stopping the drug is a better choice rather than adding steroids. That's what we felt. Surgical options have been discussed by Dr. Diwan also, who is a known surgeon, that because of the multiple sites being involved, the surgery was practically out of consideration in this case. It could have been a single site, as Dr. Sanjeev said, surgery could offer in these cases cure along with the chemotherapy. So that can also be considered. And I'll take this opportunity to request our DDG TB that please make the facility for TDM available across the country. India is a big country. We are almost sharing 27, 28% load of the world, whether to drug sensitive TB or TB. And we are getting many cases being a referral center that where TDM is required. And it is good that people are aware about this. It was so much discussed. That means our colleagues are aware that there is something called TDM which exists. We can help in such cases. So the facility for TDM, at least one in North Zone, one in South Zone, East Zone, West Zone, like that. We can have 8, 10 sites where TDM facilities can be made available. So that should be considered by the central committee to improve the management of such cases. So that's all I wanted to convey. And once again, I thank all the faculty involved and the presenter Rishi also for this case. And again, if you have any other question or suggestions, it is most welcome. Thank you.
Thank you very much, sir. Thank you very much.
Thank you, Dr. Singla. So, Dr. Rishi, presently patient is on what regime?
Sir, ma'am, actually after 6 months of the treatment, bedaquiline and delaminate was extended, and as linezolid was stopped, ethionamide is added. But after following that, again, by the end of the 10 months of the treatment, she started having this psychotic symptom and negative thought, even though she is having this suicidal tendency. So, like, we are planning to stop this cycloserine. So in that case, the drug that we will be left with after 12 months of the treatment will be delaminate, bedaquiline, and cycloserine will be stopping, and ethionamide. So we are having 3 drugs right now. And after completion of this 12 months of treatment, she is planned to extend bedaquiline and delaminate along with ethionamide to continue this TP for 18 months. And yes, ma'am, after starting the treatment, she responded very well. All the lesions were starting disappearing within the 2 months of the treatment, and they were quite happy. Regarding the clofazimine, yes, as sir said, she is a daughter of a doctor, so they were not convinced to get clofazimine added in the regime. So right now she is on 3-drug regime: bedaquiline, delaminate, and ethionamide, and cycloserine is stopped because of this ADR, that is suicidal tendency.
You see,
I may add here that those cases who have taken clofazimine, if you have operated these cases, the pigmentation is down into even the subcutaneous tissue and fat also. It's quite a deep pigmentation. It is not just skin pigmentation. I'd had the occasion to operate upon some cases who have taken clofazimine. So the cosmetic concerns of the family and patient are reasonably justified. That's all I can say.
You see, in this case, the patient's mother is a doctor, and we started treating her from July 22 onwards, and we had started the second line drugs. But I remember she still keeps on calling me. At that time, we really had to counsel the mother that she needs second line drugs. She was not convinced at all. She said it's always sensitive. Why are you giving the second line drugs? So these cases really, there are challenges in the management in the field, and you have to justify, you have to counsel the family that why we are thinking of second line drugs in a case where repeatedly it is showing sensitive. So that's another challenge which we face in the field.
Thank you, Dr. Singla. So what we just discussed was a clinician's perspective, but at the ground level, there are many issues which have been highlighted in the chat that, facilities of TDM are unthinkable. We cannot think of it. WGS is almost impossible because again, it is at a very limited center. Compliance, because this was a VIP patient, things are different. Otherwise, we know that in the periphery, not much of adherence is being done. Like it's given, patients are given 1 month medicine or 2 weeks medicine. So there's no supervision happening as much as it should. And then regarding second line drugs, many of the medicines are not there in the field. It's a big challenge these days because stocks are depleting, and the state has to procure and give it to the periphery. So traveling of drugs to periphery is an issue these days. So these are some challenges which we face at the field level, but I think with time things will improve. We have Dr. Sanjay Tandon and Dr. Mahesh who want to ask the question. Yes, Dr. Sanjay.
Thank you, madam. I am from Madhya Pradesh, so I can give my experience in treating lymph node TB. Number one, after we have switched over to FDC, it's my experience. We have not done a study on this. My experience is this, that lymph node TB with the current FDC regime does not respond properly. Number two, in Madhya Pradesh, there has been a wrong practice of instructing every TB patient to take TB tablets at intervals. Say if the patient is advised 5 minutes or 10 minutes interval, this may increase to 15 minutes or 20 minutes by the patient. And we have seen so many failures with this instruction that we have advised patient to take all the 4 drugs, all the 5 FDCs together, and then the patients respond. I congratulate Dr. Rishi for bringing up this case, but then we are also facing problem with TB lymph node. These are my observations. Thank you, madam, for giving me an opportunity.
Thank you, Dr. Sanjay. Could you introduce yourself? Are you a district TB officer?
No, madam. I am at a private medical college. I am professor and head of pulmonary medicine department at People's Medical College, Bhopal.
Okay. Yeah, welcome. Thank you, sir. Yeah, Dr. Singla, you would like to?
Yeah. You see, thank you, Dr. Sanjay, for your sharing your experience. You see, it's a national forum we are discussing. So what I request is that this is your personal observation and not sort of published or properly analyzed or compared with the daily treatment. So, and we have not observed this in our institute that after switching over, I mean, you are saying that the FDC versus this, I'm sorry, I mixed up the gradient. After switching to FDC, we have not observed this thing that after switching to the FDC, there is a lack of response or a poor response to the TB or pulmonary. So let the others also see this in that perspective, and then we can make our opinion whether FDCs are not as good as giving the drugs. By the Central TB division, they have a strict procedure by checking the content of the drugs, and then only the FDC comes to the market through the Central TB division. So as of now, I think we should not go home with this message that FDCs are not as good as taking the drugs separately, whatever is available today by the Central TB. That's
no, I am sorry if I have conveyed that message. but it has been my experience and I stress that fact. And what I can tell you, my personal experience is that if we increase the dose,
I think, sir, we are not able to hear you, but your point is noted and taken. You being at medical college, you have your experience, so we've noted that, sir. And moving on, we have a question from Dr. Shubha. Dr. Shubha? I think, yeah. Yes, Dr. Shubha, you wanted to ask a question? Dr. Shubha? I think she's raised it by mistake, if I'm not mistaken. Okay. So are there any other questions?
Yeah, Dr. Neeta, I'm Dr.
Yeah.
Manpreet.
Yes,
I have
Dr.
a question.
Yes.
Yeah. So I want to ask Dr. Rishi, I think you already said that all the lymph nodes have subsided by now. So when was the last culture done? Any culture is positive at present?
The last culture was performed when the patient visited to NITRD, and that report was available after almost 2 month end. Later, those lesions were healed, and there was no sample available to get it for the culture.
I
So,
think Dr. Rishi, what she wants to know is what month of treatment. Is it 10th month or 12th month of treatment?
no, ma'am, initially, at the time of presentation at NITRD only, the culture was performed. Later, there was no sample available because the patient very well responded to the treatment and those lesions were started disappearing. So that's why there was no basically sample available to perform the culture. This is the one limitation. And the patient is having a very good response to the treatment. Even the subsequent this CT was performed and those lesions were very well reduced. So it's very difficult to get sample from small sub-centimeter, like small size lymph node of measuring 1 centimeter.
Okay,
So
thank you, Dr.
right now you don't have any sample which can be sent for culture.
No, ma'am. Right now, all lesions are healed, basically.
Okay.
So we don't have any place to get the sample.
That is just because a patient is on bedaquiline and delaminate, I just wanted that patient should be like repeatedly done for DST for bedaquiline if sample is available. That is.
Yes, ma'am, definitely. The only thing is the limitation to get the sample.
Yeah.
As what I like the problem that we are facing in this case, as the patient is from a well-educated family, already had trouble to get this FNA done in the multiple time. And now she is responding. So still like getting sample repeatedly, despite there is no evidence of enlarged lymph node, is difficult in this case. So this is one of the limitation for us to get the repeat culture done.
Okay. Okay. Thank you.
Dr. Mahesh, are you there? You had raised your hand.
Hello.
Yeah, Dr. Mahesh.
What is the reason the drug is showing sensitivity in LP and CBNet? Still, it is not working.
Okay, so basically, Dr. Sanjeev, Dr. Sanjeev, sir, are you there? Okay, so yeah, Dr. Sanjeev is there. So basically, the question is, what could have been the causes of failure to FDC or not?
So, yeah. So I think we have discussed this before, Dr. Mahesh. So the first one, obviously, in a patient like this is the patient actually taking the drugs or not? So we will start with compliance. So even though the drugs, the second possibility obviously is, are we looking at a resistance? Now we have done a LPA and CBNAT. Am I audible?
Yes, sir.
Yes. So we have done a LPA and CBNAT, which looks at specific, genetic mutations, which look at, RPOB and CAT-G and INHA. So probably, there might be other locus where there is resistance, which we might be missing, which can be helped if you are doing a phenotypic DST or a sequencing. The third possibility is that, despite the resistance not being there, the patient can still fail the regime. Can be due to various reasons. Could be due to, absorption being subnormal. Patient may be taking the drugs, but adequate doses may not be reaching the, bloodstream and reaching the tissue, which is for which we do the therapeutic drug monitoring. The other possibility is that many of these lesions, particularly extrapulmonary lesions, the drug may be getting into the blood, but adequate concentrations may not be reaching the tissue where the drug is required. So in that case, that is what Dr. Diwan was saying, some of the laser or certain techniques are used to increase the penetration of the drug in that particular local site. And that is where, surgery would actually work in some patients, even though it's sensitive, the drugs may not be reaching the particular area in adequate concentrations. Of course, there are other unexplained reasons also where we do have patients like this, where you cannot show any of these causes, but still patients don't respond. And then you consider clinical failure and go ahead with a different regime, which we did in this particular case. I think Dr. Rupak Singla probably can add to what I said.
Yeah, I think as Dr. Sanjeev said, especially in case of EPTB or in cases of thick walled cavities, sometimes it happens that the drugs, even if it is being absorbed, does not reach the site, like walls of the cavities or the lymph nodes. And these cases may not respond to treatment, even if they are getting the adequate dosage and they are compliant with the treatment. So that is possible.
So thank you, sir. And are there any more questions? So before I, summarize the case or close the case, we would like to have your feedback. Last clinic, we hardly received any feedbacks. And your feedback is very, very important for us, to know how we are doing and how we can improve. So there is a link given on the chat box. Please take the, fill in the feedback. And so with that, we would now come to, there is a question by Dr. Lokesh. I'm sorry. Yes, Dr. Lokesh.
Good afternoon, ma'am. My concern is there any plan of CTD to monitor the serum drug levels for such cases which are not responding and still sensitive?
CTD.
It's difficult to comment,
My thought is for the program. NTP is having any plan to impose the things, get the serum drug levels for such resistant cases?
Yes, that's what through this forum I have requested once again to the Central TB Division to consider the facilities of TDM being made available at least at 6, 7, 8 sites across the country. And I'm sure they will look into it and they will consider this facility to be available.
Thank you. Thank you, sir. Thank you, sir.
Yeah, Dr. Ritu, any your comment?
Yeah, ma'am, thank you so much. Just one comment to make in continuation with what Dr. Sanjeev sir was saying regarding INH. It's a possibility that we might be missing, but for rifampicin, 98% of mutations are covered. So sensitive is practically sensitive. So WGS and phenotypic DST not being done could only give a very, very remote cases only answer. That is the only thing I wanted to add. So because that message should not go that we may need to do phenotypic or a sequencing in case of rifampicin coming sensitive in such cases. We'd rather go for the therapeutic drug monitoring. I hope I'm audible.
Yes,
yeah, Ritu,
yeah, Dr. Ritu, I think I also totally agree with you. So, vast majority of our lymph node TB and all, they just respond to our treatment in 6 months and we don't have to do all these things. It's for the very rarest of rare cases where you're taken, like, I'm talking in this case who has taken 2 years of treatment with the same drugs and not responding. That is only scenario in which I would consider this. So I totally agree with you. So this is in the rarest of rare cases. And I totally agree with you that it should not be routinely asked.
Thank you, sir. Thank you.
So we come to the end of our clinic. And so today's patient was a difficult to treat extrapulmonary tuberculosis patient who had repeatedly taken FDC and was not responding, and where clinicians decided to call it a failure and start the all-oral longer regime because it was a widespread disease where we had multiple lymph nodes. So they went in for all-oral longer regime. And within all-oral longer regime, they had many challenges because patient had ADRs and they were hardly left with any drugs at the end of 6 months because they had to stop bedaquiline, delaminid, Levo and Linzo. So all 4 drugs gone. The challenge was what to give as continuation phase in this treatment. And so through this case, we have learned that Vidacline and Delaminate can be extended beyond 6 months. And for this patient, we would be giving it for entire duration of treatment along with ethionamide, cycloserine, or replacing any of these drugs if needed with pyrazinamide or PAS, whatever would be available at that time. So that was the case, which was very difficult. Thank you, Dr. Rishi, Dr. Talasar, Dr. Sanjeev Nair, and Dr. Singla for such a fruitful discussion. Thank you all for joining the clinic, encouraging us, and giving us all an opportunity to learn. We look forward to meeting you in our next clinic. Thanks a lot. Thank you so much.
Thank you very much.
Thank you. Thank you.
Thank you. Have a good day.